As you all know, this is the program for the postgraduates. And the main aim of this program is to help the PGs to prepare for their examination by making them to present a case in the presence of an internal faculty and an external faculty. So today we have Dr. Sharanya MS, junior resident from Gokulam Medical College, Trivandrum, Sri Gokulam Medical College, Trivandrum. And as a mentor, Dr. Rekha, associate professor from Sri Gokulam Medical College, Trivandrum will be there. And on behalf of KSOS Scientific Committee, I welcome Dr. Mankala, who is the head of the Department of Cornea and Refractive Services at Aravinda Eye Hospital, Coimbatore. Welcome, ma'am. Welcome to this program.
Thank you, sir.
So with these few words, I hand over the program to Dr. Rekha, who will be the mentor of today's program. Over to you, Dr. Rekha.
Thank you, Dr. Bastin. Good evening, madam. Madam, can you hear me?
Yes, ma'am, we can hear you.
Okay. Sharanya, can you share your presentation, your PPT? So I invite Dr. Sharanya, a junior resident, to present a case. Yes. So over to you, Sharanya. Sharanya, I think you are muted.
One minute.
Put in slideshow. You're muted, Sharanya. Please unmute yourself.
Yeah.
So I am presenting a case of some. Can I hear you, ma'am?
Yes. Go on.
Okay. I'm presenting a case of 7-year-old male patient. He's a manual labor residing at Kilimanur, presented with complaints of foreign body sensation of left eye since 4 days, pain, redness, and watering of left eye since 2 days. History of presenting illness. The patient had a history of foreign body fall in the left eye while trying to pick vegetable from a plant, Kovake, 4 days back in the evening. He thoroughly washed his eyes. With tap water, but the foreign body sensation was still persisting. He went for routine work for the next 2 days. Then he developed mild pain in the same eye 2 days later, which was insidious in onset, continuous and dull-aching in nature. No diurnal variation, no aggravating or relieving factors. He also noticed redness, watering, and mild discharge from the left eye. Patient visited local hospital on the same day and was started on moxifloxacin eye drops, 1 drop 4 times, carboxymidyl cellulose eye drops, 1 drop 6 times, and homatropin eye drops, 1 drop 2 times, left eye, and oral analgesics. Then referred to higher center for further evaluation and management. No complaining of defective vision, photophobia, colored halos, itching, and headache. Past history. There is no history of type 2 diabetes mellitus, systemic hypertension, and dyslipidemia. No history of ocular surgeries. No history of spectacle usage. No history of any drug allergy. Personal history. Normal sleep and appetite. Regular bowel and bladder habits. Patient was a chronic alcoholic and smoker. Family history. There is no relevant family history. General examination. Patient moderately built and nourished, conscious, cooperative, and oriented to time, place, and person. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Patient was febrile, pulse rate 76 per minute, normal in volume and character. All peripheral pulses felt equally bilaterally. Carotid artery pulsations felt bilaterally equal with no bruit. JVP normal. Blood pressure 130/70 millimeters of mercury in right upper arm in sitting position. Systemic examination, CDS S1, S2 normal, no murmurs. CNS, higher mental functions normal. Cranial nerves normal, no focal neurological deficit.
Sharanya, can you pause for a minute? Has Dr. Mangala left?
Yes, I'm here.
You are here. Okay, sorry. We can continue.
Respiratory system air entry bilaterally equal with normal vesicular breath sounds. GIT, soft, non-tender, vowel sounds heard. Local examination, no abnormal head posture, no facial asymmetry, no proptosis, ptosis, nystagmus or strabismus, no palpebral, preauricular or cervical lymph nodes, no sinus tenderness, no neck swelling. Hirschberg test, orthophoric, ocular movements, ductions, versions and vergences pull in all directions of gaze in both eyes. The right eye, visual acuity unaided 3/60, the left eye 1/60 with projection of rays accurate in all quadrants. The visual acuity is not improving with a pinhole or glasses. Near vision, N36 with +3 dioptric sphere in both eyes. Color vision normal in both eyes. In examination of right eye, eyebrow normal, eyelids normal, eyelashes normal, regurgitation of pus on pressure over lacrimal sac area absent, lacrimal apparatus normal, orbit normal, conjunctiva normal, cornea normal size, shape, luster and transparency, corneal sensations were normal, anterior chamber, peripheral anterior chamber depth Van Herix grade 3, no abnormal contents. Iris, normal color and pattern, pupil 3 mm, round, direct light reflex brisk, consensual light reflex brisk and no RAPD. Lens, nuclear sclerosis grade 3 and cortical cataract. Examination of left eye, eyebrow normal, eyelids, mild upper and lower lid edema present, eyelashes normal, regurgitation of pus on pressure over lacrimal sac area absent, lacrimal apparatus normal, orbit normal, conjunctiva, there was mild conjunctival congestion, circumcorneal congestion, chemosis, and mild mucopurulent discharge. Cornea, normal size, normal shape, a 4 × 3 mm grayish white irregular shaped corneal ulcer seen in the inferonasal part of the cornea in the paracentral area near 7 o'clock position, 2 mm from the nasal nimbus and 3 mm from the inferior nimbus. The ulcer has raised edges and feathery margins. Surface appears dry and the ulcer extends up to the midstroma with extensions into the midstroma all around the ulcer. Endothelial plaque of size 2 × 2 mm seen under the ulcer. Multiple satellite lesions of 1 to 1.5 mm in size seen superiorly and temporally 1 mm away from the main lesion. Immune ring of Vesely seen around the ulcer and the surrounding cornea shows stromal edema up to the midstromal level. And the picture showing the fluorescent staining of the overlying epithelial defect. Corneal sensations were normal. Anterior chamber, peripheral anterior chamber depth, Van Herix grade 3, Sayer 3+, a hypopyon of 1 mm height inferiorly with a straight upper border which was immobile. And the picture of anterior segment drawing showing the anterior and the striatum section. Iris, left eye hazily due to corneal ulcer and corneal edema. Visible areas show normal color and pattern. Pupil pharmacologically mid-dilated. Lens, nuclear sclerosis grade 3 and cortical cataract. Dilated fundus examination. Distant direct ophthalmoscopy of both eyes shows peripheral dark shadow against red glow. And slit-lamp biomicroscopy with +78 diopter lens and indirect ophthalmoscopy with +20 diopter lens. Right eye, media very hazy due to lens opacity. Discan vessels hazily seen and appears normal. Macular details not clear. The left eye, media very hazy due to corneal ulcer, corneal edema, anterior chamber reaction and lens opacity. Discan vessels easily seen and appears normal. Macular details not clear. IOP at 10 a.m. right eye 12 mm of mercury and left eye 8 mm of mercury. The provisional diagnosis, right eye nuclear sclerosis grade 3 and cortical cataract, left eye fungal corneal ulcer with hypopyon, progressive stage, nuclear sclerosis grade 3 and cortical cataract.
Dr. Mangala? Dr. Mangala, are you there? You're muted, madam. Can you unmute?
Okay, madam. My video is again a problem, but anyway, yeah, I'm here, madam. Yeah.
Okay, you can go on, madam. We can hear
Yeah.
you.
Yeah. Okay. Okay. Okay.
Yeah, your video is back, madam.
Yeah.
You can see.
Yeah. Yes, ma'am. Sorry. Some technical this thing. Okay.
You understand.
Okay. Sharanya, you were telling from, I think we can go from the history. You were been telling about the history of injury with plant matter, right?
Yes, ma'am.
Yes. So what are the clues which we can get from the history with injury of any, whatever the material was causing the injury, no? What all we can get clues from that history? What all history you will ask?
Now we can ask the history of any trauma to the patient.
Sorry?
A trauma to the patient, ma'am.
Yes, trauma with what? If
Trauma
trauma
with
with the,
vegetative matter, animal tail,
okay.
any history of foreign body fault.
Yes. So what all it will signify? Like if it is a foreign body, iron foreign body, a patient is in the foundry or somewhere, no? The foreign body with iron foreign body. So what clue we will get? What kind of ulcer it can be? It will need not be all the time hard and fast, but what all we can suspect? If it is a trauma with a foreign body, iron foreign body, what you will suspect? What kind of organism we can suspect? Saranya or anybody?
Yes, ma'am.
Others can also
Staphylococcus, ma'am.
answer.
Staphylococcus.
So it can be a bacterial ulcer. Commonly it can be bacterial, and then we can, yeah. So then if you have a trauma with vegetative matter as for this patient, no, what you will suspect? At least what we can, from the history.
Fungal corneals.
What, anything else?
Acanthamoeba.
Yes, wet mud. Wet mud, if it is also associated with wet mud, you can have an acanthamoeba. Yes. Then what else? Injury with, or if a patient has had, is a patient is a contact lens user, did you ask if that patient is a contact lens user, what organism you will suspect?
We can suspect Pseudomonas. Acanthamoeba.
Commonly, yes.
Common.
Yeah. So this patient had come to you and saying that they had injury with the vegetative matter. Anything else also you will ask in the history? They are from a village. So anything, any more significant history which we can ask to the patient?
Agriculture worker.
Agriculture worker, sometimes they commonly do in their place, no, when they get injury with anything.
Paddy fields. Working in any paddy fields.
Sorry, ma?
Rice fields, ma'am.
Some native medications, correct? Like they may use oil, they may use breast milk, they may use rose water. All those things can also add to the increase in the infiltrate or contaminate the contaminated solutions for washing and all, no, it can also maybe the reason for the ulcer also. Sometimes you may have only abrasion, then it can lead to that. Okay. So what are all the systemic history, which is very, very importantly, we have to ask in any ulcer patient? Systemic history.
History of diabetes mellitus we can ask.
Hmm.
Then any immunosuppressive states.
Hmm.
Then steroid use history, ma'am.
Yes.
And any nutritional deficiencies.
Yes.
And history of any contact lens use.
Yes. So then also like can have asked about the collagen vascular disorders also.
Okay.
So sometimes collagen vascular diseases also will cause melt and other things. Correct? Correct. So coming to the clinical features, Mark, can you describe it again in a gist? How big was the ulcer? What was the shape of the ulcer?
Madam, the ulcer is 4 into 3 millimeter, grayish white, irregular shaped ulcer seen in the inferonasal part of cornea in the paracentral area near 7 o'clock position, 2 millimeter from the nasal limbus and 3 millimeter from the inferior limbus.
Okay.
And the ulcer has raised edges and feathery margins. Surface appears dry and the ulcer extends up to the midstroma with extensions into the midstroma all around the ulcer.
Okay. So coming to the location of the ulcer, can we come to narrow the ulcer cause, like when it is in the center or in the periphery? Can you narrow down the causes or the reason? Like if it is in the center.
Central ulcer can be mainly due to pneumococcus.
Central ulcers, mostly it can be infective. Correct?
Peripheral ulcers, peripheral ulcerative keratitis, marginal keratitis, Murren's ulcer also.
Immune mediated. We can tell immune mediated, but even infective ulcer can occur in the near the limbus also. That doesn't mean all ulcers near the limbus are only immune. Correct? Yes.
Yes.
And before going to the ulcer, in the adnexa, what all important things which we have to see in the adnexa?
Dacrocystitis the patient have, which can cause. Then lid infections like blepharitis. Then entropion, lag of thalamus. Trichiasis.
From the lashes, you tell from the lashes, trichiasis, blepharitis, MGD. So then, as you told, ectropion, entropion, that also we have to look into. Yeah, correct? And then any facial palsy or anything, that also is very important. Correct? In the ectropion patient, what commonly we may get only because of ectropion? Ectropion.
There will be constant exposure of eye to the outside, which can cause dryness of. corneal surface and exposure keratopathy.
So what is the common organism? Like common organism.
In a corneal ulcer or in exposure.
Exposure. Yes.
Bacteria.
It will be mostly bacterial. It can be Staphylococcus also.
Staphylococcus.
Yeah. Then Adnexa, you have seen the lids. What else you will look into?
Lacrimal saccarea.
Yes. Very importantly, we have to see for the lacrimal duct patency. That is very, very important. So the patients having block in the lacrimal duct, what is a common organism? Commonest organism?
Actinomycetes.
Sorry, ma'am?
Actinomycetes. Canaliculitis.
No, Staphylococcus. It's a commonest thing. Okay. So then you see the Adnexa, you see the lids, you see the sac, and then ocular surface. Any significance in ocular surface? Anything we have to see?
Dry eyes. You have to look for.
Yes, if the patient is having a good tear film or it is a dry ocular surface. So that will give us a clue of a dry eye patients. And so this is all to narrow down your causative organism. So this particular patient, so what is your provisional diagnosis?
Not a fungal corneal ulcer with hypopyon, lactate stage.
Okay. Why do you say it is a fungal corneal ulcer?
There is a definite history of injury with a vegetative matter, ma'am. Also, the symptoms are much more than the signs. Then, on examination, the clinical findings are more suggestive of fungal corneal ulcer, like irregular ulcer with the feathery margins. Then, the dry surface, and there is history of there is an endothelial plaque and multiple satellite lesions, and the immune ring of Vesely can also seen around the ulcer.
You could see an immune ring also in this patient?
Yes, ma'am.
What is it called?
Immune ring of Vesely.
Okay. Can it be anything else? If only the immune ring is there?
Can be viral hepatitis.
Immune ring, second differential diagnosis, immune ring. You have immune ring?
Nacanthamoeba.
Okay. So how will you proceed with this case? Any ulcer patient, how will you proceed with this case? Did you draw a diagram, ma? You have drawn a diagram? Yeah, that is very, very important. How will you divide the cornea? Front view of the cornea, how will you divide? For drawing the diagrams, color coding and drawing diagrams? 4 quadrants. That is the side, no? Slit view. So how do you divide the cornea when you draw a diagram? How do you divide the cornea? For drawing diagrams? Quadrants, 4 quadrants you can, no? Superinasal, inferonasal, superiotemporal, inferotemporal. Then how will you divide? Central, paracentral, periphery,
and margin.
Yes. So this is very, very important. So when you put a diagram, no, when you see the patients and when you divide this into all these 4 quadrants and this central rings, then you can easily draw the diagram and you can place the ulcer diagram. So color coding, you are comfortable with color coding? Color for, yes?
Color for immune ring,
Hmm.
I draw in yellow color.
Okay. Epithelial defect?
In green, ma'am.
Green. Okay. Corneal edema?
In a light blue color, sky blue color.
Blue. Okay. Okay. The patient has a hypopion?
Yes, ma'am.
Okay.
Hypopine in a 1 millimeter height, which was immobile, and upper surface is straight.
Okay. Is there any difference in the hypopion for the bacterial ulcer and the fungal ulcer?
In bacterial ulcer, hypopine will be mobile and it will be sterile, ma'am.
Hmm.
In fungal, it will be non-sterile and upper border will be of dome shape most of the cases.
Okay. It can, fungus can pass through
Fungal
the,
hyphae can pass
yeah,
through
it
the
can
descendants
come and it can
membrane and
reach
reach.
the, yes,
and
yes. Yeah. Madam, you are, yourself, madam.
Yes. So how do you represent the corneal edema? Different parts of the depending on which layer is involved, how do you represent?
Epithelial corneal edema can be drawn as a round, small round bubbles.
Yes.
Sky blue color, and stromal edema can be drawn as a diffuse light.
Stromal edema? How do you represent?
Vertical strips.
That is due to what happens when you have a stromal edema? Why is it represented as lines? What happens to the decimal?
There will be stretching of Descemet's membrane.
You will be having folds, Descemet's membrane folds. Right. Okay. So, what are the other causes of hypopyon other than corneal ulcer?
Hypopyon can be due to bacterial corneal ulcer, as in Pseudomonas.
Okay, other than corneal ulcer? The other common cause for hypopyon?
Endophthalmitis.
Okay, even commoner than that? Any other inflammation of the anterior segment?
Toxicity antidepressant.
No. You know actually.
Antidepressants.
Yeah. Antideviatis. I don't say it like this. Yeah.
Yeah, that's right.
So can you describe what are the investigations you did to this patient?
We can first do the general investigation, like complete blood examination, blood test, the urine routine examination, then RFT and LFT. Then we can check the blood sugar levels. Then specific investigations for the fungal ulcer, like smear, then culture, and other investigations. In the smear, we can do corneal scraping and can send for KSOS.
Please describe how you take the scrapings.
Scraping taken under sterile precautions, ma'am. After instilling proparacaine eye drops with either using 26 gauge needle or Kimura spatula or number 15 bar particle blade, we scrape from the base and edges of the ulcer, and it we send for gram stain and KH. Then we can also send for culture, like blood culture, chocolate agar, and subrose dextrose medium for bacteria.
Madam, you are muted, madam.
Sharanya, you have a very limited material. So what you will send? What culture you will send? What slide you? What stain you will use? Only limited material. We are not able to take all the culture and all. So what you will?
Can send for gram stain, ma'am. Which differentiate the bacteria, fungus, Nocardia, and Acanthamoeba species. So if only limited amount of scrapings are there, only we can send for gram stain.
Grams and culture?
And culture, blood agar.
Yes, blood agar. Yeah. Okay.
Before taking the scrapings, will you do anything?
We wash the mucus debris.
Not wash. You can just clean up the base. You can remove the necrotic material.
Okay.
So as madam is telling, if you take the slough, no, nothing will come. So the slough and the dip, those dead thing we have to clean off, and then you have to take from the base of the ulcer. Scrape nice deep from the base of the ulcer. Okay. So how will you place in the blood culture plates? Is there any pattern, or you just put it?
T-shaped pattern.
Okay. What is the significance? Why it should be like that?
All the materials that we collected from the tip of the needle, we can scrape if we do in a C-shaped manner.
Yes. Is there any significance in putting it in a particular manner or particular shape? Why is it done like that? Is there any significance for that? To put it in a C shape?
The growth of organism can be disillusioned.
So when you see some growth out of that C shape, it might be a contamination of the culture medium also. So that is why we always see for the pattern. So that growth should be in the pattern where we have smeared the material. So that is very, very important. Okay. Okay. Do you know what are all the specific culture mediums for the organisms commonly used?
Subrose dextrose agar, potato dextrose agar, and Reinhardt infusion agar.
The broth.
Broth.
So what organism commonly, for what organisms do you use these culture mediums? Potato dextrose.
Yeah. Fungus, Fusarium, Aspergillus.
Oh, fungus, potato dextrose, fungus. Yes. Okay. Blood agar, what all you will see? Bacterial and fungus is also possible. Chocolate agar?
Very specific organism like Neisseria, fastidious organisms need to.
Anaerobic organisms. Okay. NNA? NNA? Non-nutrient agar?
Acanthamoeba.
Acanthamoeba. LJ medium?
Tuberculosis.
Okay. Atypical mycobacteria. Okay. So these things you should know. Okay?
Okay.
Okay. So we are sent for the investigations. So how did you proceed then?
And after from the results, we look for any growth of fungal elements or any bacteria in the.
So how long does it take for the fungal growth to take occur? Do we wait for the reports to come?
No, after KOH and gram stain, no, we empirically start the antifungal, topical antifungal and antibiotics. And after obtaining the report, we change accordingly.
Okay, so you don't have any material for scraping at all. The ulcer is very deep. What all the other modalities which you will go for detecting the organisms? Do we have anything else to
We
see?
can go for in vivo methods like confocal microscopy, looking for fungal hyphae,
Mm.
and acanthamoeba can also see in
Yeah, so
confocal
we can do
microscopy.
confocal microscopy. Then
Then
anything else we can do to find out the organism? You can go for a corneal
Any
biopsy.
other- Yeah.
Small punch biopsy, corneal biopsy you can do, and subject for HPE. So the
then
ulcers. Yeah.
paracentesis.
So then if you have a posterior ulcer, we can go do a AC tap also. These things also we can try. If you don't have means you can, if you have a deep ulcer and there is no chance of scraping. Okay. For this patient, what did you start? Treatment?
We started topical antifungal, natamycin 5% is hourly, ma'am.
Mm.
Then carboxymirase cellulose hourly.
Mm.
Then atropine eye drops is started 3 times.
Mm.
Then oral analgesics and paracetamol daily.
Okay.
So how do you classify the antifungals?
Antifungals are classified into pollines, salts, then antimetabolites, then echinocandins. Pollines
Anti-metabolite.
are
Anti-metabolite. How does it come here?
pollines are large azoles and pollines are amphotericin and nystatin, natamycin. Azoles are imidazoles and triazoles. Imidazoles contain miconazole and fluconazole. Triazoles were itraconazole and ketoconazole. Then echinocandins are capsifungin.
Any other drugs? That's all.
Voriconazole.
Anything else? Yeah, Posocon.
So these things I think you have
Posaconazole.
to, yeah, questions will come even in theory exams. No, latest, what are all the latest drug in treating fungal ulcer or antifungals, latest antifungals. Definitely you might get a notes in theory also and in practicals also. I think you people can get.
So suppose the ulcer is not responding to your treatment. Then what's the next line of management? How will you proceed?
If not responding,
Not healing, non-healing ulcer. What will you do? Next.
we can stop the treatment for 24 to 48 hours and then
You stop
restart
the
again.
treatment.
It's a fulminant ulcer. For 2 days you will stop.
We can go for therapeutic keratoplasty,
That's the last resort. No?
intrastromal or intracameral.
Not Naranya, here you have just started with a single antifungal agent. So what else can you do?
We can add multiple
Hmm.
second line antifungal agent, topical. Then oral antifungals can also start if the patient not responding to single medication.
Very small ulcers, you will start oral antifungals. Small one like this 3x for your patient. In this case, when you will start oral ulcer?
If in the large and deep ulcers, and
Yes.
if there is an associated scleritis
Yes, very good.
or post-penetrating erectoplasty patient presented with ulcers and endophthalmitis cases we start.
Yes, only when it's going to reach the limbus, large, deep ulcers, we go. Otherwise, for all small ulcers, you don't do. First thing you ask the patient's compliance. First, we have done a scraping, you have got the material, you have got the culture also, you have given the right medicine. First, ask for the compliance of the patient. Then you can even do a rescraping to find out any other secondary infections is there. Meanwhile, as you said, we can go for intrastromals, which if the ulcer is anterior to mid-stromal, maybe a little deep. But if it is too deep, intrastromals might not work. Then how many times you can give intrastromals?
We can try 3 times.
You can try many times. Actually, if it is responding, you have to see how many days you will give, like how frequently you will give the intrastromals. Once in 3 days, okay? Once in 2 to 3 days you can give. So you can give multiple times if you feel the ulcer is healing, the edges are. So what are the signs of healing ulcer?
There will be reduction in stromal infiltrate, stromal edema.
Mm.
The edges will become sloping,
Mm.
and there will be reepithelialization and vascularization of ulcer.
Mm. Okay.
And the edges become smooth and transparent.
First, symptomatically, the patient will be little better.
Better.
The congestion will come down. The ulcers will become rounded. And then the periphery starts healing. The edema comes down. And then, as you told, it will start reepithelialization. So for all these points, you have to have 1, 2, 3, 4, 5 perfectly in order. Hmm? So that this will also be a short notes for you. Stages of healing ulcer, all these things. Okay. So then finally, what you will do? Nothing is working.
We will go for therapeutic erectoplasty.
Okay.
What is immune? This vessel is immune ring, Sharanya?
The deposition, it's a immune complex deposition.
From where do you get
And
these immune complexes?
the reaction between fungal antigen and the WBCs which get deposited
What
around
is the
us.
source of the antibodies then? Antigens,
From the
of course, are
limbal vessel,
released by the fungi. What about the
limbal,
antibodies? Yes, they
limbal
reach through
vessel.
the limbal capillaries.
Ma'am, do we have any more cases or is this the only case?
The only case, madam.
Only case. Okay, okay.
Actually, we have the culture reports available. We want to see that.
Yes. Oh. Okay. So what is the common drug which we give for Fusarium species? Common drug.
Topically, natamycin 5%.
5%. Atomycin. Yes. It's aspergillus.
Aspergillus,
What is the common antifungal which we give?
Voriconazole.
Amphotericin B. So aspergillus, these are all common. You can even give nata for an aspergillus. It can work for them. If it is working, need not change. But commonly, these work better for these patients. Okay. Okay. So how will you differentiate a bacterial ulcer and a fungal ulcer?
Bacterial ulcer from the history. The fungal ulcer will be history of trauma with vegetative matter. Then the symptoms will be more in bacterial ulcer, but that will be less in fungal. And the discharge will be purulent in case of bacteria, while that will be mild in case of fungal ulcer. And the clinical examination, there will be dry looking ulcer with irregular surface, feathery edges, and immune ring, which can be seen in the fungal ulcer. But in case of bacterial ulcer, there will be well-defined infiltrate with no lesions and immune ring.
Which ulcers you get? Purulent discharge. Which ulcers you get?
Bacterial ulcer, Pseudomonas
What is it?
pneumococcal.
Yeah. What is the typical description of the discharge for the Pseudomonas ulcer?
Greenish discharge.
Greenish pus-like discharge. Okay. So how fast the Pseudomonas ulcer progresses? How
It was
fast?
very,
Is it
very
fast?
rapidly.
Slow? 5 days, 10 days, 12 days?
1 to 2 days. It
One
will,
or two, within hours it will progress. What is the other organism which is equally bad, like very fast progressing ulcer? Immediately after the injury. Very fast with melt.
pneumococcus.
Pneumococcus. No what? What else? One more. These two things should come into your mind when you see a
IPM.
No.
them also will be slow only. It will be like a fungal. Actually, slow fungal. It may mimic like a slow fungal. The other thing, broomstick injury. Broomstick injury means what you will think? End of thalmitis. Immediately, second day end of thalmitis. Bacillus. Bacillus and Pseudomonas you have to have always in mind when you get a very fast progressing ulcer. Immediately the next day it will become, you will have a melt and all perforation, everything. So whenever the broomstick injury is very, very dangerous. You should, when the history is broomstick injury, immediately we have to bombard with antibiotics and we have to check for the vitritis. So in the investigations, what are the investigations you will do for the corneal ulcer you told? So scraping and along with that we have to look for the fundus. That is very important. If you are able to see the fundus, that is fine. We dilate and see the fundus for the media clarity. There is any vitritis associated with vitritis or not. If you can't do that, you have to definitely do an ultrasound to look for vitritis. What are all the indications for therapeutic ulcer?
Progressive and for therapeutic electroplasty.
Yeah, therapeutic entoplasty in any ulcer.
The progressive ulcer, in spite of
Mm.
medical management,
Mm.
perforated ulcers.
No, it will be like there are points, no? Like
The ulcer which extend to the limbus.
yes,
Progressive ulcers, in spite of medical management.
yes,
Ulcers associated with secondary glaucoma.
yes.
Sir, reaching the limbus.
Limbus, severe non-healing ulcer, progressive, severe fulminant progressive ulcer, reaching the limbus, desmetocele, perforation, end of thalmitis, and like when it reaches the limbus, threatening for a scleral involvement. These things and all you should tell at least 4 or 5 points. It should come continuously. So any other adjuvant therapies are there for treatment of the corneal ulcer apart from topical medications, intrastromals? Do now latest current
Photodynamic therapy.
sorry ma'am?
Photodynamic therapy.
Yes. What is that?
Like using a rose Bengal strain,
Yes.
as we do in the cross collagen cross linkage in keratoconus. Here we are strengthening the stoma.
Yes. So both are phototherapy. So in the both there is a chemical reaction which is going on which will release a. Madam, is it too much for them or we can
No,
just
no, ma'am. She's
no?
exam going. She actually needs this
No, maybe
point.
these things whether it is too much I don't know.
She's a final year
Yeah,
resident, ma'am.
that okay. So that releases a singlet oxygen which will help in the what it does actually in keratoconus also what the collagen cross-linking does.
Strengthen.
How does it strengthen the cornea? Collagen cross-linking is to strengthen the cornea which will prevent further progression. How does this happen?
So photoisomerization.
The mechanism, madam, is
Well,
asking.
simply how we will tell what happens.
UVA lights which passes through the
So tell me the procedure of collagen cross-linking.
especially take the rose Bengal strain
Collagen cross-linking.
where we put the riboflavin.
Yeah, that is the collagen cross-linking, correct? Collagen
Then
cross-linking.
then UV light is exposed.
No, whatever, when you are asked about the procedure, no, you have to go in the correct order. So what you will tell, remove the epithelium. Epithelium is scraped off, 8 millimeter. Normally, if they ask you have to tell 8 millimeter of epithelium is scraped off. Then what you will do?
Then we will put the drop of riboflavin.
That you should not tell like that. Then the examiner will get they will get no, they will get irritated. No, you have to tell like I will scrape. I will put like that. You should not tell. You should tell like if 8 epithelium is scraped off. Then riboflavin drops. What is the percentage of riboflavin drops? That drops you are going to apply for how many minutes? Then what are you going to apply for how many minutes? It should come step by step. Step one, step two, step three. This collagen cross-linking and all, you should not have any hesitation. Okay. So you scrape the epithelium, then you put the riboflavin drops. Then what you will do?
Then UVA light is passed.
UVA light is passed for how many minutes?
10 minutes.
What is that procedure? 10 minutes. What is it called?
Dresden protocol.
Dresden protocol. What is Dresden protocol?
Here
Which is the conventional C3R therapy? Conventional. What is the name of the conventional C3R? That is the Dresden protocol. Okay. So tell me the Dresden protocol. What? Tell me.
here 3 millivolts per centimeter square. This is given for 10 minutes or 3 times.
No, you should read C3R. You should read Dresden. You are not right. This is very simple question. Ma, this can come for your theory also. So C3R, types of C3R, conventional C3R, what is the accelerated C3R, what are the different modes of C3R? Like now we have to have lot of things, like epithelial on, off, contact lens, lenticule, all those things. I think this is a very simple, commonly asked short notes also for you, theory exam also. Like even in an ulcer, see how now we have dragged you to the C3R. Like this, it can come. Any case, you will be asked about all these things. So C3R is very, very common thing. C3R, you should know exactly the value of the energy, the timings. Okay, that you should definitely know. You should be very thorough. There should be no hesitation. It has to come like one, two, step one, step two, step three. Oh, this Dresden protocol is this. So what is the difference between the Dresden and the accelerated? That we should know. This is the time. So that the energy is changed. So what is that law which is usually, which way, by which law this accelerated C3R came? There is a name for that law. Okay. So this C3R you have to know in and out. That is a very common question you will get. So one is C3R and one is riboflavin photodynamic therapy. So both these phototherapy causes a two things they does. Like how they strengthen the cornea, in the same way in corneal ulcer, they do strengthen the cornea as well as they have mild antibacterial activity also. So the collagenolisis and everything can come down. Lot of studies are going nowadays, and it is few studies now. It has become like a adjuvant therapy, a good adjuvant therapy for non-healing ulcers. We can use it as a adjuvant therapy. Okay. Okay. Madam, theory,
Yes, madam.
surgery and all, they will tell, madam, like surgery, TKPs, procedures, steps of surgeries,
Which surgery, madam?
no, this therapeutic kertoplasty or anything, no, they have to know, no, madam, the steps and all, everything they will have to know, no, procedure.
Yes, they have to know.
Can you tell therapeutic kertoplasty procedure?
Therapeutic keratoplasty is procedures similar to the penetrating keratoplasty, 1
Hmm.
millimeter margin of the
What is the very big difference between a penetrating keratoplasty and a therapeutic keratoplasty? Which step is very important? What is the difference? In the penetrating keratoplasty, whatever be the size of the scar or anything, you take only the central part. Central window only we are going to create. So, but in infective keratitis, it's not a central one. We always focus on the infiltrate size. Wherever the infiltrate, it can be near the limbus. So your graft will be eccentrical. Wherever the graft is there, you have to go and mark the size. So in penetrating keratoplasty, it is not in that way. No. Wherever the scar is, how big the scar is, we want only the central window of 7.5 to 8 m. Correct? Okay. Then first you mark, drape the eye, give a thorough wash. Then you have to, very important thing is you have to mark the infiltrate. So how much clearance will you give? These things and all should come immediately, 1 to 2 mm. That's all.
1 to 2
Immediately you have to bombard with answers. These are
1
all
to
very
2
simple
mm.
questions people will ask you. 1 to 2 millimeter, you have to definitely give a clearance. Then
Then
next
using
step. Hmm.
trusting the exercise
Hmm.
cornea and host button.
Partial trephination of the cornea. Then you have to prepare the button. How big you will prepare the button?
0.25 to 0.5 millimeter.
0.5 millimeter you have to take. Bigger than the, larger than the marking. So you have prepared the button. Then you have to go for the full thickness cut. So then you are going to cut entire the cornea. And then you are going to place the donor button. And then
Interrupted sutures.
interrupt. First you have to place the 4 cardinal sutures and then rest remaining you have to place. Anything else you have to do before putting the button and suturing? If you have a cataractous lens or a
We
clear
can
lens, what you will do? Young patient clear lens, old patient cataractous lens.
in inpatient, we can go for NGD with
So in young patient, you just leave the lens. But do you do any other step before suturing the graft?
we can irrigate the NGD chamber.
No, you need not do that. You have to do a peripheral iridectomy. That is very important. Okay. Phakic eye, particularly, we have to do a peripheral iridectomy. Why do we do a peripheral iridectomy? To prevent
Angle closure.
angle closure and
Pupillary blocking.
okay. So then in the old patients, you remove the cataract.
That's it.
Cataract and try to preserve the PC. Maybe if at all the graft survives or if it fails also, later when we plan for a PKP, we can use that PC for a secondary IOL. So then after the so we'll put sutures and and form the AC and close the case. Yeah. Okay. Anything, madam?
No, madam.
Mhm.
So shall we wind up the case, madam?
Yes, madam. Is it talk? Actually, if we talk again, we can even talk for any in another an hour also. But
Yeah.
yeah, it is good. Saranya, you presented very well. Your presentation was good, and that is fine. But we have to expect any question in any case. So
Yes,
you
that's
have
right.
to, you should know basic things. You all have to read simple things. So that and all we have no choice. If we were not answering an like latest drug, that is fine. But C3R or the procedure, therapeutic cataract procedure, a small incision cataract procedure, no, that if you are not answering how LASIK is performed, that is fine. But therapeutic cataract definitely you should know. It should come like step one, step two, step three, like that. No hesitation. Certain points should be very clear for you. How big I am going to take. What are the steps? What precautions I will take? What precautions you will take before a therapeutic cataplasty? We need to give mannitol. We need to control the sugar. So these things and all you should know. Like that only your case discussions will go. And in any, all these things are a notes, no short notes or what notes for you. Theory also you will get all these only culture media in culture media alone you can get as a question. You can get a broad thing like how do you manage a corneal ulcer can also be a question, or it can be like only medical management of fungal ulcer also can be a question. So for both we have to be prepared. So if it is like that, how you will shorten everything and put it in a nutshell. But only one topic is asked, how you will elaborate that particular topic and give the relevant points. So like that we have to prepare. Okay. So it is good, and you have to learn more common things. We have to be very confident and thorough. Okay. Okay.
Well, thank you so much, madam. It's a wonderful discussion. We got a lot of points, not only for the PGs, for us faculty also. It is very useful. To hear from an expert is actually very, something very good.
Yes,
Thank you
madam.
so much.
Thank you, madam. Thank you so much for the opportunity also. Maybe next time when we have, if at all, we can even have little half an hour more before so that we can
Yeah,
have little more discussions
more
also.
time. Yeah, I know.
When I am also very happy to be a part of your academic program, madam. Thank you so much for the
Thank you
opportunity.
so much. Thank
All the
you.
best for all students. Thank you. Thank you.
Thank you.
Thank you.